Good afternoon, and welcome to today's webinar titled The Safety Planning Intervention to Reduce Suicide Risk, sponsored by SAMHSA, developed under the TA Coalition contract, and presented by the National Council for Behavioral Health. My name is Kelly Maston from the National Association of State Mental Health Program Directors, and I would like to thank you all for joining us today. Before we introduce today's presenters, I would like to go over a few housekeeping items. Today's webinar is being recorded. The recording, along with the PowerPoint presentation slides, will be available on the National Council's website at www.thenationalcouncil.org and the NASHBID website at www.nasmhpd.org within 3 to 5 days. For participants only, audio is being streamed through your computer speakers with no need to connect by phone unless necessary, in which case the phone number is listed in the notes section on your screen. If you're having any technical difficulties during this webinar, please type your comment in the Q&A pod on the right side of your screen, and someone will be able to assist you. Please also type your questions for the presenters in the Q&A pod, and at the end of the presentation, we will ask as many questions as we can. The PowerPoint slides are available at the top of the screen where it says PowerPoint Presentation for you to download. Please click on Upload File to download the slides. At the end of the webinar, we ask that you take a few moments to complete a short evaluation for us. Please know that we do not offer CEU credits for our webinars, but a letter of attendance will be available for you to download on your own when we switch to the evaluation screen. The letter can be found at the top of the screen where it says Letter of Attendance. If you have any questions, my email address will be available at the top of the screen during the evaluation as well. I would like to thank SAMHSA for allowing us to share this information with you today. And again, thank you for joining us. I will now turn it over to Flannery Peterson, Senior Manager in Practice Improvement for the National Council for Behavioral Health, who will introduce today's presenters. Flannery?
Thank you, Kelly. Today's presenters are Drs. Barbara Stanley and Gregory Brown. Dr. Stanley is a professor of medical psychology in the Department of Psychiatry at Columbia University and director of the Suicide Prevention Training, Implementation, and Evaluation Program in the Center for Practice Innovations at New York State Psychiatric Institute. She is also a research scientist in the Division of Molecular Imaging and Neuropathology at New York State Psychiatric Institute, where she is a principal investigator and co-investigator on several research grants from NIMH, American Foundation for Suicide Prevention, and the VA. Her research focuses on all aspects of suicidal behavior, non-suicidal self-injury, and borderline personality disorder, including assessment and intervention with suicidal individuals, clinical factors relevant to suicidal behavior and self-injury, and neurobiological and biobehavioral influences on suicidal behavior. She also oversees the development of suicide prevention training for clinicians throughout New York State. With her colleague, Dr. Gregory Brown, she developed the safety planning intervention that is used throughout the VA and on crisis hotlines across the United States. Dr. Stanley is a member of the American Foundation for Suicide Prevention Research Grants Committee and was the president of the New York Metropolitan Area Regional Chapter for FinDet Foundation. She is on the executive committee of the International Academy of Suicide Research and editor-in-chief of their official journal, the Archives of Suicide Research. She also serves on several journal editorial boards. She's the author of over 200 publications, several edited and co-written books, and has received several awards for her research and leadership in the field. Dr. Gregory Brown is an internationally renowned expert in suicide prevention whose work has led to transformational advances in the treatment of suicidal individuals. His research aims to develop and evaluate the effectiveness of innovative, targeted interventions designed to reduce vulnerability factors associated with suicide behavior in high-risk populations, and to examine and improve the implementation of evidence-based treatments into real-world settings to prevent suicide. Specifically, Dr. Brown is a developer, along with his colleagues, of two clinical interventions for individuals at risk for suicide, including safety planning intervention and cognitive therapy for suicide prevention. The safety planning intervention is an evidence-based brief suicide prevention strategy that's been used in research and widely disseminated in healthcare settings, including the Veterans Health Administration. He also developed one of the few existing evidence-based psychotherapy interventions, cognitive therapy for suicide prevention, which has been shown to prevent suicide attempts among individuals at high risk for suicide. Dr. Brown is the principal investigator, co-investigator, and research grants from NIMH, American Foundation for Suicide Prevention, in the Department of Veteran Affairs in the Department of Defense. He is the author of numerous scientific publications in the area of suicide prevention, and he has received several awards for his contributions to the science of suicide prevention. Currently serves on scientific advisory boards for the American Foundation for Suicide Prevention and the Cohen Veterans Network. And with that, I would like to welcome today's presenters and hand it over to Dr. Stanley, who will get us started. Dr. Stanley, I think you might still be on mute.
Hello, everybody. I'm Barbara Stanley, and I'll be presenting today with my colleague, Greg Brown. I just would like to briefly go over the learning objectives as we get started here. So what we would like to do is to just give you a basic overview of the safety planning intervention and talk about some of the challenges and perhaps offer some of the potential solutions in doing safety planning, particularly in the population with SMI. We're going to talk a little bit about some of the research on safety planning, and then I will talk about what are some of the adaptations and some of the challenges in doing safety planning with individuals who have serious mental illness. So I am going to talk about a bit about the background for safety planning. Then Greg is going to talk about, the how to do it, the nuts and bolts of safety planning, and then we'll end by talking about, some cases doing safety planning with people with SMI. So one of the really important things to remember is that suicide risk varies with time. It does not remain constant with anybody, including those with serious mental illness. And so we call this this curve that is presented here as the suicide risk curve. And when we do safety planning with people, we show them this curve. And it's actually really important to show this curve because what you can see here is that if somebody doesn't act on their suicidal feelings, the urges, the risk comes back down. And so it's really important to remind people that their risk doesn't remain constant. And so at the beginning here of the curve, we see that there is a point at which the risk escalates, and it kind of goes, we have it as a smooth curve here. It differs for people. Some people it goes up smoothly like this. Some people it goes up kind of slowly and then up quickly. Other people it is a kind of a very low rise. But for here we just show that the urges to make a suicide attempt or to kill oneself escalate, and what we want to do is to help people identify what are their warning signs so that they can start to enact their emergency plan. In other words, to pull out the safety plan and to begin to use it so that they don't act on their suicidal feelings. So this, I'm spending a bit of time on this because this risk curve really serves as the basis of psychoeducation for people who are suicidal. And as a clinician, it's really important that you explain this to the suicidal individual. So we identify what the warning signs are here, and that is the indication that the person who is suicidal needs to pull out their safety plan and begin to use it. The important thing to know is if a person doesn't know what their warning signs are, they're not going to know that they are in a suicidal crisis, and they're not going to know to pull out the safety plan. Okay, so what is the safety plan? It's actually pretty simple, but it turns out that it is not the simplest intervention to do. So, so the safety plan starts with a list of warning signs that you would have identified with the person. Again, it's this part of the curve here. What are the warning signs? And it goes on to say, okay, so when these warning signs are present, what are the thoughts, feelings, and behaviors that are associated with being in a suicidal crisis? And so we identify those warning signs. When the warning signs are present, that means we go to step 2, 3, 4, and 5 in that order. And then we'll talk a little bit about step 6, which is making the environment safe later. So who is good to use the safety plan with, this intervention with? So anybody who is at increased risk for suicide is a candidate for a safety plan, but it's important to remember that we should not be doing a safety plan with people who need immediate rescue. And this is mostly people who you're speaking with over the phone, who you're not in contact with in the moment. So, so we've done a lot of training with crisis hotlines. And if somebody has called into a crisis hotline, the crisis hotline workers will do safety plans, but if that person is in danger of making the suicide attempt right at that moment, so for example, has a gun and they're holding on to the gun and they can't tell you that they're going to put the gun away, that person is not appropriate for a safety plan. You have to do what you need to do to rescue them, to save their life. So, other people who are eligible or who are good candidates for a safety plan are people who have had a history of suicidal behavior, including people who have had aborted attempts. In other words, have had like false starts, have taken pills out, thought about taking them, put them out in front of them on the table, and then decided not to do it. That would be an aborted attempt. Or people who have made preparations for suicide, or people who have made suicide attempts. Also, people who have had serious suicidal ideation, had thoughts of killing themselves and have made a plan and have had intent but didn't act on it. They are good candidates for doing this. So in other words, anybody who has had a suicidal crisis. But in addition, I just want to talk a little bit about, before I move on, about people who may not be appropriate, at least at that particular moment. So there are two categories that I think are really important to think about. People who are in some way or another, intoxicated, or so they have had a lot of alcohol on board, and their cognition is not clear. Same with people who have recently used substances and who are still under the influence. So you can't do an intervention like this with somebody who needs clear cognition. And you can't do it unless they have clear cognition and they are not clear. The other group that is very difficult to do a safety plan with is somebody who is acutely psychotic at the moment, and maybe made a suicide attempt recently that they were acting on the basis of a command hallucination. And so it's very hard to do a safety plan with somebody who can't think about what their warning signs are, because in their mind they may not have a warning sign because it was a command to them. So I'll return back to this a little bit later. So the approach that we take here is that people may have trouble recognizing when a crisis is beginning to occur. And so that's why we put the big emphasis on having people tell their story, their narrative of their suicidal crisis, even if it's kind of sketchy in their mind, so that we can help them identify their warning signs. And so we emphasize that because we don't want people to be way high up on that risk curve before they start to think about, oh my goodness, I'm going to kill myself, I'm going to make a suicide attempt. So we emphasize identifying warning signs prior to or at the very beginning of a crisis. The other part of our approach here is that we know that problem solving and coping skills diminish during an emotional crisis or during an emergency of any sort. We're not great problem solvers when the fire alarm is going off in our building about, do we do this first, that first, what do we do second? And so we need a plan in place. A third thing that is really important is that this is an intervention, and I make this a big I there, a capital I at the beginning of intervention. It is not, although you walk away with a form and the clinician fills out the form, it is not just a form to be filled out. You have to think about this as a clinical intervention. And the thing I will often say to clinicians is, if you're going to think about this as a form to be completed, don't bother. This is a clinical intervention, and the client and the clinician have to work together to complete this intervention. And you'll see why as we go through this. Okay. So I used the example of a fire alarm. This is an example of a firefighter explaining to elementary school kids, what do you do should you catch on fire? You know that from our elementary school days that you stop, drop, and roll. And so we know that this is a very rare event that somebody would catch on fire, just like we hope that suicidal crises are rare events. But the consequences of not knowing what to do are dire. And so, even though it's a rare event, it's a very bad event. And so we want to make sure that people know what to do. And so this is how we talk with people about having a safety plan. We don't want you to have to think about what to do when you're in an emergency. We want you to have a plan. And so I'm saying these words to you as the attendees here, but these are the exact words that we say to the people that we are doing the safety plan with. So we explain all of this. So there is a bit of psychoeducation that goes along with doing a safety plan with our clients. So the safety plan, the way that we have developed it is it's stepwise, and it creates a tool to go from strategies that are simply by yourself, like what do you do on your own to diminish your crisis, all the way up to going to emergency rooms. So we really like people to think about what they can do completely on their own first. And this is not rocket science. These are very, very simple distracting strategies. We put a lot of emphasis on distraction here to help get people through the crisis. And if we have time later in the discussion, I can talk more about why that is. But it starts within self, and then it builds all the way to seeking external resources. But we want them to capitalize on, first of all, their own resources, then their natural environment. Who are their people in their environment? Sometimes people have a lot of support in their environment. Sometimes they have very little or none. And so we work with them. The thing that we also tell people is, look, we have this plan here for you, and that's stepwise, but please don't think that you have to go through this in a lockstep manner. You go from one step to the next, but if it doesn't seem like it's going to work to you, or you just don't have the patience to try it, and you're feeling that much in a crisis, you just go on to the next step. If you have somebody in outpatient care, you can do the safety plan and in one session, and then you should be looking at it, revisiting it over time, and revising it based on any new information, based on if they used it and certain things worked, certain things didn't work. Okay, so I'm going to talk a little bit about some of the data that support doing safety planning. And this is just one example. There are other examples of support showing that this type of approach is helpful with suicidal individuals. This just happens to be the biggest, the largest sample. So we did a study, a project within the VA. It was a demonstration project where we implemented safety planning, and it's important to note here that it was not safety planning alone. So we did safety planning in the emergency department with follow-up phone calls, and 2 people who were seen in the emergency department for suicide crisis. So they came in either having made a suicide attempt, having had an aborted or an interrupted attempt, or they had serious suicidal ideation. And the physician in the emergency department interviewed the patient and decided that that person did not require hospitalization. And so typically what do we do with people like that? We would say, okay, you don't need hospitalization. You are free to go. And we would often, the standard would be give them a referral and have them go see their, either if they have a clinician on the outside, or give them a referral to a new clinician. So we thought this is a pretty dangerous circumstance to, where somebody comes in, makes a suicide attempt. We know that if they've made a suicide attempt or they've had a suicidal crisis, they are at increased risk for having another suicide event over the next 3 to 6 months. And we're sending them home with nothing other than a referral. And so we decided to try this intervention in the ED. And so we did the safety plan in the ED, and then we did these very, very brief follow-up phone calls until people got seated in treatment. At the time that we did this project, it was a long time before people got were able to get care in the outpatient department in the VA because they were so overburdened. And so we wanted people to get something while they were waiting for an outpatient appointment. So what did we find? We saw that so we had sites, several sites that had the intervention that we called the safe bed intervention, which included safety planning plus follow-up phone calls. In our article, we called it SPI plus to delineate that they got follow-up phone calls with the safety plan. And so we found that, in fact, giving SPI plus was associated with about 45% fewer suicidal behavior over the next 6 months. So now it's important to note that the percentage of suicidal behaviors was not great even in the control group, but we pretty much halved the number of suicide behaviors. In addition, we found that people who had this intervention were more likely to get into outpatient care. And so that we thought was really pretty important. And again, we increased the odds significantly. Now, we also did a mediation analysis to see, well, maybe it was not so much the intervention that resulted in a direct impact on suicidal behavior, but that there was a mediation, that the people that in other words, we did the intervention, it impacted outpatient care, getting into outpatient treatment, and that in turn had an effect on suicidal behaviors. That actually wasn't the case. It was a direct impact of the intervention on suicidal behavior. So, this is numbers, but I actually like to give people the flavor of what participants, what clients who had the intervention have told us. So we did a qualitative study where we interviewed people, and so this is just a couple examples of what people said to us. So one person said, it gave me the opportunity to more clearly define the signs when my mood is beginning to deteriorate and when to start taking steps to prevent further worsening. This is exactly what we would hope for in terms of somebody being able to identify their warning signs. Another person said, how has the safety plan helped me? It saved my life more than once. And this actually has been a recurrent comment that we have gotten from participants who have had the safety plan. So I'm going to turn it over to Greg in a minute, but I want to just stress here, if we look at the steps in doing the safety plan, you'll notice that in the pink arrow, part of the arrow there, it says to complete the safety plan. And so there are a bunch of things that need to happen, several steps you can see here that need to occur before you actually do the safety plan form completion. And so this is why we stress so much that this is a process between a clinician and a client. You can't just give the form to the person and say, okay, here is the form, fill it out. You know, I understand you've had a suicide attempt. Here's a form for you to do by yourself. And so I think I can turn it over to you, Greg, now, and you can talk about this slide and then the follow-up slides.
Thank you, Barbara. Hi, everyone. I'm Greg Brown. So as Barbara mentioned, I'm going to go over kind of each of these blue flags, really, and then go over the red flag in detail with the focus on how to actually do it. And you'll see, while the end product of the safety plan is relatively simple, as it should be, because people need simple instructions when they're in crisis, the process of getting there is actually a complex clinical process. And so that's why I want to kind of spell it out in a little more detail. So the next, after you do your risk assessment and you determine that this person is appropriate for safety planning, then we do what's called the narrative interview, which is actually really part of the risk assessment. And we asked individuals to tell their story about a specific recent suicidal crisis. It could be an episode of ideation, or it could be a suicide attempt or aborted or prep behavior. It doesn't matter as long as there's a story behind it. And the idea here is we want to help people identify their warning signs, how the crisis escalated and then de-escalated, so that it really makes it clear that the risk for suicide fluctuates over time. And so it also really helps to do this to establish rapport and a working alliance with the person that you're speaking to. If you really take the time to listen to people, they're going to be much more open and receptive to collaboration. So we think this is a really important step for a number of reasons. So when you're doing the narrative part, you're asking people things like, so can we talk about your overdose in a little more detail? I'd like to hear exactly what happened, what led up to you taking the pills. And then I kind of shut up, and I'm just being a good listener. I maybe lean forward a little bit. Maybe I do some capsule summaries or ask a few questions if the story is unclear. But I basically trust that the patient is going to tell me exactly how they got from the warning sign to the top of the curve and then beyond. So as you're doing this, you want to use your clinical skills and just empathize and validate their feelings. So here's an example of what I mean. And as I'm listening to people, I'm kind of thinking about the timeline as almost like it's a movie shots, movie screen, and I kind of start thinking about, what were their feelings, what were their thoughts, what was the activating event, what are their warning signs? All of this kind of bopping around in my head as I'm listening. And so this is a story where this was a soldier who was stateside, and his wife had left him several months ago because he was working a lot and would come home and kind of watch TV and not participate with the family that much, and was kind of not involved with chores or helping out with the kids. And the wife kind of got really discouraged, and she left and moved to another state to live with her parents, who could provide the emotional and physical support. So he was very angry about this, and that she had abandoned him, and he had to move out of his house and where he was staying, and he couldn't find a place where he could keep his dogs. She took the dog. He was really feeling very alone, and the key reaction he had was, I thought it would never come to this, and this began to affect his work. He began to become irritable at work, and then he would snap out at his peers, and then he would withdraw, and this was kind of noticeable behavior. And so his commander one day called him into his office and really laid into him about him being irresponsible and not doing a good job with working with coworkers, and he was taken aback, and the commander even asked about his home life, suspected that things were going well at home, and but he didn't open up to his commander about that. So he's driving home, and he has this thought, what do you do when everything starts falling apart? And he was stressed, so he got home and he cracked open a few beers to kind of chill out. But then he thought, well, I'll just call my wife and see and tell her, what happened and get some advice. But that turned into quickly to an argument, a blame game, and he ended up feeling very overwhelmed and just at the end of the call, just began to have a lot of emotions going on, a lot of rambling thoughts that would happen. And some of these thoughts include, I can't take it anymore, I don't know what to do, I feel helpless, my life is going down the toilet. And that led to thoughts about suicide, which is maybe it'd be easier if I just ended it, everything would be fixed. And he got his gun that he kept in his nightstand next to his bed loaded, and brought it down to the kitchen table and was like leaning in and working with it, and he would put it up to his chin, really thinking about pulling the trigger. But during that period of time, and we're only talking about a few minutes here, his buddy called, and he had heard about what happened with at work that day, and he broke down and told the friend everything, and the buddy said, hang on, put the gun down, I'm coming right over, and to help you, and I'll be there, just hang on. So the friend dashed over, and he stayed overnight, and then brought him into the clinic the next day, and he told the clinician there that he didn't want to die after all, and he wanted to get help. So if we take that story and we put it on the suicide risk curve, you can see here that on the left side of the curve, the activating event really started with the supervisor was critical. Now this curve is already elevated because we know that his wife leaving from, separating was maybe upped his risk some, but so this curve is on top of that. But the key thing here is that his thoughts about everything's falling apart, drinking the beers, and arguing with the wife, that feeling he can't take it anymore, that maybe easier if I ended it, put the gun, loaded gun to his chin. And then you see on the other side how the risk comes back down that kind of corresponds to the what he was telling in the story, till the point that he was willing to engage in mental health treatment in the clinician's office. So this only happened about a period of a couple of hours. This was not a lengthy period of time. So once, and when I work with patients, what I do is I actually draw the curve. We put the things on the curve so people can see very clearly, how their story maps on to suicide risk. And it also is very helpful for identifying warning signs, which I'm going to talk about in a minute. So at this point, Barbara was saying you educate people about the crisis, that it doesn't remain constant. You're referring to the curve, that your feelings went up for a period of time, for maybe a couple hours, and then they started coming back down over the next couple of hours. And so this helps people to see that that the risk comes and goes. So at that point, you can then introduce the safety plan, the method, to help to recognize warning signs and take action to keep the curve from escalating, and to see how it comes down. And so I usually, at this point, once they understand the suicide risk curve, I'll say, so what we want to do is help you develop an emergency plan for you that's going to work in crises like this, so that you don't ever get to the point of holding that gun in your hand again and wanting to pull the trigger. And so the way we're going to do that is through a series of steps that are organized from beginning with warning signs, and then go from internal coping strategies to external coping strategies and so on. And we'll fill this out together as a team, with us both kind of brainstorming ideas and then making sure that it's really going to work with you. So I kind of set the stage for how we're going to be talking about this, so that it's communicated that I'm not just giving him the plan to fill out on his own with no input from me, nor am I kind of directing the person from on how to do a safety plan. We're working as a team together. So when I'm going over this, I'll say it's a series of steps, and you progress through each step listed here in the plan. If you recognize your warning sign and you pull out your safety plan, you start following what you've listed, and if you do what your internal coping strategies and they work, you kind of stop. You're done. Your crisis is over. You can wrap things up and go on about your day. But if you find that you try some of the internal coping strategies and they're not helpful, then you go to the next step on the safety plan, and you keep working the safety plan until you get to the point where, if needed, you can call the Lifeline, the National or you go to the ED, or you call a provider who can help you with the risk. But the idea here is if one step doesn't work, then you go to the next step, you try that. If that doesn't work, you go to the next step, and so on. And we also say that you don't have to go through all the steps. If you're feeling an acute suicide crisis, you go directly to the ED. You don't have to work the steps first before going to the ED if it's not appropriate. So coming back to the beginning of the safety plan, I'm going to explain how to go through each of the steps briefly. So the first step is to identify the warning sign, and really the important point here is to know that it's important to be able to become aware of your warning signs so you can take action, work your emergency plan before the crisis escalates. So once people start, going down a path and get to the point right where they're ready to pull the gun out, well, there's not a lot of opportunity to intervene. So if you back up in the chain of events and intervene sooner, that's going to probably work better. And so the other thing is that it's very simple, that it's important to know your warning signs to remember to get the safety plan. When we first started doing this, we explain the safety plan intervention, and people would have a safety plan, and then they come back and we're in a crisis, and we'd say, well, did you use your safety plan? And they say no, and the clinician would say, well, why not? And the patient would say, well, because I forgot. And so forgetting about to use the safety plan is kind of like a big barrier to using it. So we want to make sure that the warning signs are very specific and kind of jump out at you. So that's why you explain the purpose of it, and then you ask them what were your warning signs. So you can go back here on the suicide risk curve. I'll just go back a couple slides here, and you can see here, you look at this and you say, well, how about the supervisor was critical as a warning sign? Well, that's what we call an external warning sign or a trigger, and that's okay to use a trigger, but the problem with a trigger is it's not often very specific, and the supervisor can be critical and you're not suicidal. So we prefer to use some reaction to the external event, usually a thought or a feeling or behavior. And so you have the next thing that happened on his way home, everything falling apart. So that's a thought he had on the way home. That's a really good warning sign because it's specific. And so you kind of keep going up the curve here, looking for other warning signs and identifying them and vetting them in a similar manner.
So Greg, can I say one thing here? If you go back to the curve.
Oh, sure.
Yeah, so you notice that Greg knew a lot about the suicidal person that led up to, that occurred before the supervisor was critical, that he had been having trouble with his wife over time, and that things weren't going well. So that part doesn't go, that is like kind of, like the ground on which the crisis occurred. But you notice that that doesn't, that doesn't appear on as a warning sign here. It's just that kind of, it's the part where that, like the minutes or just hours before the crisis develops into where it gets extremely serious. So it isn't like we don't start back on this curve like weeks or days before the crisis. It's hours, minutes before the event occurs. That's all I wanted to say.
Yeah, thank you, Barbara. And it's important to be specific. So if you're talking in generalities about motivations for living and dying, you're never going to get to this level of detail. That it's going to be more difficult to identify specific warning signs that actually occurred if you're talking more about general concepts like motivation. Okay. So identify the warning signs. What were they? And if they're not very specific, if they say, well, when I get depressed, and then say, well, how often do you get depressed? Well, I'm depressed every day. Well, are you going to use your safety plan every day? No. Well, it doesn't sound like that's the best warning sign because you have it a lot, and you're not going to use your warning sign a lot because you're not in crisis all the time. So how do you know when you're going to have a crisis? And then the person would say, well, when I get depressed, I get feeling really helpless and alone. And they say, oh, okay. And is that when you start to feel suicidal or your risk increases? They would say yes. That sounds like a really good warning sign there, and that's how you would identify it. So you can tell there's a lot of back and forth conversation that happens, and this is true throughout filling out the safety plan. This is why it takes 30 to 45 minutes to do. You can't just do it in 10 minutes because then you would have no way of brainstorming or vetting the response. So the second step on the safety plan, once people have filled it out, is to identify internal coping strategies. And this is, as Barbara said, one of distraction. That the idea here is if you don't think about your problems that are causing the suicidal crisis or don't think about suicide, your risk is going to go down. And so the idea here is to kind of put your suicidal crisis aside and do something else where it's going to be incompatible with thinking about suicide. But it doesn't have to necessarily be something that is calming and or pleasurable. It just has to be distracting. And so sometimes doing things like playing video games or running or doing exercising, they're not calming activities. They're actually very busy activities. The point is that they take people's mind off their coping strategies. Now, the reason we go here first is because people, when they're suicidal, are often alone, and they often don't necessarily feel like reaching out for help. And sometimes people can manage some fleeting suicidal thoughts on their own without having to call the crisis hotline or go to the ED. It's not that we're saying that crisis hotlines aren't helpful or the EDs aren't helpful. They most certainly are. But we're trying to empower the patient to use their own resources to help them cope with a crisis, and we think that's really important. So when you're identifying distracting activities, you want to make sure that you're identifying strong distractors that are going to be helpful. You're going to vet them in the same way you vetted the warning signs and identify any barriers and problem solve their use. So you may say, well, what have you done in the past to distract you from your problems or thinking about suicide? And usually people come up with some pretty good things just off the top of their head. They're willing to talk about it. Sometimes they don't, and you have to kind of brainstorm with them a little more and make suggestions. But often they do readily come up with things, and so then you're off and running. And so you want to make sure that you vet the response and make sure it is specific and individualized. So if somebody says, well, I like to play video games when I'm in a crisis because I really can focus on the video game and so on. And you can write down, play video games, but that's not terribly individualized, and it's likely that the person may not do it. But if you say, so what kind of games do you really get into? And they say, well, I play football, on the video games. And it really takes me outside myself. I forget about time. Time passes. They say, well, okay, video football games, let's put that down. It's a much better response. And are you able to access the video game easily? And they'll say yes. And if it was something you're really willing to do in the middle of the night, they say yes. So you think it's going to work? They say yes, and so you're done. Sometimes people come up with things that are not very helpful or are vague, in which case you say, that doesn't sound like such a good distractor for you. Can you think of something else? Okay? All right. So once you've listed several internal coping strategies, the next step is to identify social contacts and social settings. And this is the exact same thing as internal coping strategies that you do by yourself, except you're just doing them with other people. So here we explain to patients that this is people as distractors. So people you hang out with, that you have a good time with, that take you outside yourself, the time passes, that provide a positive influence on your life, and you know, do some brainstorming with the patient to come up with some friends or family or acquaintances that that they may have in their natural environment. The other thing you can do is ask people if they don't have any friends or people that they don't hang out with, they can always go somewhere where there are other people. And so this might be places, it could be like the beach, the coffee shop, the mall, the grocery store, the AA meeting, and wherever there are people around that you can be a people watcher or interact with people, that's probably going to be a great distractor. And so you do the same thing there. You want to make sure you vet the responses like you do with internal coping strategies, and ask them, what is this a good place? Is this realistic? You want to make sure it's a healthy place. So if somebody says, well, I go to the bar and drink because that's distracting, and you say, well, it probably is distracting, but it probably increases your risk because you're going to be maybe disinhibited, more likely to do something to harm yourself. So it doesn't sound like it's going to be the best option for you. Can you think of another place you could go where there's people around? And so you do that kind of thing with that. And so again, for each response, you ask how likely they would do it, is it feasible and safe, and address any barriers. You do that for each and every response of the safety plan. So if that isn't helpful, then you may identify family members or friends who, on step 4, who can help with the crisis. So these are people who the patient would go to for help, tell them they're in crisis, tell them they need their support, ask them to spend some time with them and help them out. This is sometimes in the ED setting a more difficult step for people to do because they are often don't have healthy social networks, and sometimes you have to work with them a little bit more. But if you come up with at least one person, that's going to be really helpful. And you do the same thing here. You vet the response. You ask them, how likely do you think you'd be able to reach this person? Is this person going to be helpful? What might get in the way, and so on. Making sure that you also note, you may ask them, is this somebody who you'd be willing to share the safety plan with so they know how to help you in a crisis? And that's always a good question to ask. Okay, so if that family member or friend is not helpful, the next step on the safety plan is to go to identify a professional in the person's healthcare system or an agency where they can go for help. And again, this is often what people do when people are doing a crisis intervention, is that they give the numbers to the crisis hotline, or they tell them where to go to the ED, and that's kind of it. And you have no idea whether or not the person's, if you do that, you have no idea whether or not the person's actually going to call the hotline, go to the ED, or tell their therapist that they're suicidal. And a lot of people don't want to tell their providers they're suicidal. They're afraid they're going to be hospitalized them, or they don't want to let the therapist down, or there's lots of reasons people come up with for not disclosing to professionals that they're feeling at risk. So it's important to identify what those things that might get in the way and work with them a little bit. You can also ask them to contact the provider, share their safety plan with that provider, or try calling the National Crisis Lifeline and see how that works, and so on. the same idea. So finally, the last step in the safety plan, this is not really something you do when you're in crisis. It's something you do before crisis. But that's making your environment safer. And we call this lethal means counseling or lethal means safety. And what we want to do is identify the method that the person had used when they were in crisis or when they think about suicide or their plan, and then develop an action plan for making the environment safer and having not as quick access to that method. And the idea here is the same as a distraction, really. It's how do we extend the period of time that you get to the method so that the crisis has time to subside. Maybe you'll have second thoughts. And even if it's only 15 minutes, that 15 minutes could be an important period of time where the person could, have second thoughts about acting on their feelings and just decide not to and decide to follow their safety plan. So anything you can do to remove access, ready access to the lethal means, and extend the time to the obtaining it, the better. And we explained it just like this when we talk about lethal means, and that it will make it less likely that people will act on their suicidal thinking. And so if somebody says they're thinking about overdosing, then we talk about ways that they might be able to not have as much access to the medication. People, of course, need their medication, but at the same time, it's a danger. And so you have to come up with ways of safely storing the medication. Sometimes it involves getting rid of unused medication. Sometimes it involves having a family member help out with medication distribution, or having the pharmacy prescribe medication, not as much. But whatever the method is, you kind of go through the same kind of problem-solving discussion to try to determine what is going to make the environment safer. And we always ask about firearms when we do this, given that in the United States, firearms is such a lethal method, and it's the #1 method among men who kill themselves, and men are the most common, especially older men, are much more likely to kill themselves. And so ask about firearms. It can be a very sensitive topic, but if you kind of say it in a way that you say, this is a standard question I ask to everybody because I'm really concerned about, access to a firearm because it happens so quickly and it's so lethal. So do you have a firearm that you have access to for sport or for protection? And if they answer yes, then I'll ask, how many do you have? Where's the kept? Is it locked? Where's the ammunition? Is the ammunition locked? And a whole other questions that come after that. And it is important to be aware of your state law regarding firearm ownership, and in case you're in a position of wanting to counsel somebody on how to safely store the firearm. I won't get into any more detail about that, but other than to say, get some advice or get some training in firearm laws. So often people are ambivalent about getting rid of their method of suicide, and to deal with that ambivalence, we do pros and cons, and this is helping people just look at their pros and cons and then come to a decision to see the point of the value of limiting access to those methods. And this is a very effective, it's kind of like motivational interviewing, if you will, a very effective method for dealing with accessing the lethal method. People really sometimes keep that method in their back pocket just in case, that they may come to a point where they're feeling suicidal again and want a way out. And so sometimes they're very reluctant to give it up. Okay, so you might also point out the part about involving others in making the environment safer. You have a family member or person that can help carry out the plan. That's often better than and safer than having the patient do it themselves. So make sure that plan is written down, make sure there's somebody who can help carry it out, and then make sure you follow up with the person that the plan was executed. So finally, the implementation of the plan is next to the last flag in that list of flags I talked about earlier. You want to review the entire plan, make sure it works for the person. If any coping strategies are unhelpful, you explain that the person should just try the next step, but if it's working, you should stop. And then make sure they have a copy of the safety plan and discuss where they're going to keep it. And that discussion is really important because if they don't have ready access to that safety plan, they're not going to use it. So we've talked about, and sometimes people make multiple copies for the safety plan. They put it in their wallet, their purse, their pocket, bathroom mirror, the drawer by the nightstand, the glove compartment. They put it in the safe where they keep the medication or they keep the guns just in case they see that safety plan if they're reaching for their method. And so that's a really important discussion. And then finally, that's how their likelihood that they're going to use the plan and any barriers to its use. And some people take pictures of the plan, or there are apps out where you can enter the safety plan on an app. Well, the most important thing is that it's readily accessible. So if you take a picture of that safety plan and it's embedded, I know like on my phone I've got like thousands of pictures. You want to be able to find that picture really fast. In a crisis, you're not going to scroll through, hundreds of pictures to find it. So it's the same principle. Okay, and then finally, once the person is on their way and you feel confident that they're going to use it, is to have a follow-up conversation and determine whether it's been used. Ask the person, did they find it helpful? Where are they keeping it? What's working for you? What's not working for you? If it didn't work for you, why not? And always review the access to lethal means action plan and whether that was actually executed. So finally, you can see that that doing a high-quality safety plan is really important. If you just give the form to the patient to fill out, it's very unlikely they're going to come up with as good a plan as they could do with the two of you working together. And there's been several reviews, studies done. Both of these are in VA where they coded safety plans on how individualized they were and whether or not they were addressed in the medical record. JAMA did one in 2015, found that most safety plans were complete and of moderate quality, although there was a lot of variability. And a significant portion of the plans were in the medical record, but were not addressed anywhere else in the medical record. It was just done and put there. There was a second study done by Green in the VA, and they actually coded the quality of the safety plan, which is how individualized or accurate or on target the responses were. So they rated quality, and they also rated completeness, which is how filled out it was. And they found that the quality rating was associated with a decreased likelihood of suicide behavior reports within a 6-month period. So quality is really important when you're doing this and using it in your institution or in your setting. And so it's important to have an ongoing review of safety plans to improve quality. I'm going to toss it back to Barbara to go over suicide risk and psychotic illness.
Okay, so I will do this quickly so that we have some time for questions. So we already know that suicide is a significant risk in individuals with psychotic illness. About 4 to 10% of people who have schizophrenia die by suicide. It's a pretty significant percentage. And so we think that, in general, people with serious mental illness have are good candidates for having a safety plan. So psychosis in and of itself is definitely not a contraindication for doing a safety plan. But often there are challenges or obstacles that exist within the clinician as opposed to the suicidal individual with SMI for doing a safety plan. So what are some of the indications for doing a safety plan with people who have psychotic illness? So first, as you are doing the safety plan, if you want to do it in that particular moment, you have to assess the degree of reality testing and the cognitive capacity at that particular moment. It doesn't mean that they can't. So you may decide, no, they don't have good reality testing now, it's not the time to do it. It doesn't mean that, the next day or 2 weeks later, then you couldn't do a safety plan. So if the person is psychotic at the moment, they have a poor reality testing and they're extremely disorganized and they are suicidal, they're probably not great candidates for doing a safety plan. If you think about being able to engage that person in the kind of process that Greg just described, probably is not that likely. But when you are doing it with somebody who has psychosis, some of the adjustments that you can make are thinking about using simple, concrete language with them, accept baseline delusional thinking if it's not directly related to suicidal ideation. In other words, you don't have to challenge delusions. And then where possible, and this is often true with people who have first episode, involving the family or other significant people in the process. And so that's really very important, especially when you have somebody with psychotic illness who is living with their family. So here is a case example of Mr. V, who is a 40-year-old man with chronic schizophrenia. He has baseline delusions that the FBI is tracking him, recent loss of his mother, leaving him sad, lonely, and feeling overwhelmed. When speaking to him, he mentions he has recently thought about killing himself. So what's the obstacle here? The clinician has to decide, is this an appropriate intervention? So what would you want to think about? Does he have access to a gun or other lethal means? Has he made a plan? What has provoked it? And what's his current reality testing? So in this example, his delusions have not worsened, and he's not more disorganized than his baseline. He's thought of ways of hurting himself, and he's expressed a wish to be with his mother. So that's pretty common, whether you're psychotic or not, that people will have that kind of wish. He expresses a wish for help, and his reality testing is intact. So this is a very good candidate for a safety plan despite being psychotic. He generated simple warning signs like feeling sad, thinking about his mother, crying. He had no trouble coming up with ways to distract himself or turn to other people. And he concretely focused on step 6, specifically on how to keep himself away from the bridge. Every time I think about the bridge, I'll go to the park instead. So he was able to successfully do a safety plan. Now, here's another example. Mr. G is a 25-year-old male with schizophrenia. He had multiple high lethality suicide attempts. His psychotic symptoms have worsened. He is paranoid. He has ideas of reference, hallucinations, and it's all in the setting of psychosocial stressors. Comes to the clinic saying he wants to kill himself using a gun. So again, these are the questions you would ask. Does he have access? Has he made a plan? What's provoked this? What's his level of reality testing? So when questioned, he says he doesn't have a gun, but He knows where he can get one. He then begins to speak rapidly about his neighbors who refuse to leave him alone, the fact that they're keeping him up at night and he is not sleeping. And he can't reality test around the worsening delusion, and he says suicide is probably the only way out. And so this person is not a great candidate at this particular moment to do a safety plan, because he says he has access to a lethal weapon, and he has a past high lethality suicide attempt. Now, these two things alone do not make him a bad candidate for a safety plan. But the thing that does make him a poor candidate is that he's disorganized and he has a worsening delusion directly linked to suicidal thoughts, and thinking about suicide as the only option. And so if you think about how would you engage this person in the process of talking about warning signs and distracting himself, he probably would not be able to do it. And so one of the things that I would just like to end with is, when we think about people with psychotic illness, there are basically two kind of paths to suicide that we see. Often they are depressed in the same kind of way that people without psychotic illness get depressed and suicidal. So they get suicidal in the same way because they also have depression and feel very, very hopeless. And then second, and so those people are very good candidates for the most part for getting a safety plan. The other group of people are people who have things like or either delusional, and their delusions are tied up in their suicidality, or their suicidality is tied up in their delusions, or who have command hallucination. And there you can see where it's very, very difficult to think about how to do a safety plan about suicide, suicide warning signs. When I have had somebody who is like that, what I will often work with them on is a safety plan that is a little bit different, where they could feel, and this just happens to be clinically the way that I have talked about it with my patients, where I will help them notice when their thinking is kind of going off track. And for some reason, thinking about their thinking going off track seems to be acceptable to the patients I've worked with. I don't know if it's true for the listeners here. But so we then develop a safety plan, like what are the warning signs that your thinking is going off track, and then use a safety plan for that. So I think I will end here and give you some time to ask additional questions, and we can go back to the question that you started out with. Thank you for listening.
Thank you so much. Now is the time, if you have a question, you can enter your question in the Q&A pod on your screen, and we'll try to get to as many questions as possible. One question we have received earlier in the presentation that I will start off with is asking, can you speak to those individuals with substance use disorders, including among the SMI population, and how can we use the same skill sets and tools to prevent overdose deaths?
So that's a great question. So I'm assuming that you need overdose deaths that are not suicidal. I'm not sure, but when somebody has serious problems with substance use, the place where safety planning can be helpful is when they have stopped using substances and they are fighting urges to use. Some people have taken the safety plan, and instead of having it be about suicide, have it be about urges to use. And so what are the warning signs? And then enact the steps in the same kind of way. So I'm not sure if that was what the question meant. I don't know. Greg, do you have any thoughts?
Yeah, I just, obviously if the warning sign is using drugs and they become high or really intoxicated to the point they're cognitively impaired, well then the safety plan is absolutely no good. That's why Barbara's saying to back up in the chain and start talking about urges or warning signs to using and do the safety plan in that manner. Next question.
Thank you. Another question we received, a couple questions actually focused around adolescence. So are there any adaptations or considerations you would recommend when applying to or working with an adolescent? And is there a, I guess, youngest age that this intervention is appropriate for?
So we actually developed this first as in the form that it is now in a project that we were doing with adolescents. So and in that project we were doing safety planning with kids as young as 12. And so we don't have data on efficacy in that population, but kids had no difficulty age 12 and older doing a safety plan. There are a couple things that are adaptations. Number one, not including kids as people they turn to for help as people on the safety plan. You know, if you remember, people can be used in two places: people as distractors and people that you turn to for support. So it's that latter group that we make sure that adolescents never put another adolescent in that space. Number one, because kids don't necessarily give each other good advice, and number two, we don't want to burden another adolescent with having to take care of somebody who is suicidal. The other adaptation is that we tell the adolescent at the beginning that we're going to do this together. Often we'll do it alone with the adolescent, but that we're going to share it with their family member, usually one of their parents. And so we tell them at the beginning, just in case just to give the child like kind of fair warning that if they want to put things on as distractors that they know their parents won't get upset about or angry about, or tell them that they shouldn't use. And then we share it with the parents and go through, do the kind of the same type of psychoed with the parent that we've done with the adolescent, and explain what is on the safety plan and help to enlist them in using the safety plan. The other thing that I will say is that I have somebody who is working with me, one of my postdocs, who is developing and adapting this intervention for children that are younger than 12. And so she's taking it in a way and doing kind of a more pictorial type of intervention and simpler, and making the psychoeducation a little bit easier.
Thank you. Another question that we received is, do you believe only licensed clinicians should be in this role in terms of developing and implementing safety plan interventions with clients? Or, for example, can a knowledgeable, well-trained, certified peer specialist fill the role?
Greg, do you want to answer that one, or? Maybe Greg is muted. So yes, there is no reason that a peer specialist, if they are trained in how to do the intervention, shouldn't be able to do it. And as a matter of fact, I'm working with the firefighters union, and they are developing a training to teach firefighter peers how to do safety planning with other firefighters. And you can think about certain groups where it would be much more palatable to them to do this with a peer than it would be to do it with a clinician.
Another question that we received mentions that the Joint Commission is promoting development of safety plans in the emergency department for patients at risk. However, for our webinar today, a safety plan truly takes 35 to 40 minutes to develop. Are there other recommendations for how to develop safety plans in the emergency department environment?
Yeah, so that is true that the Joint Commission is promoting it. So if you notice, one of the things that takes time in doing a safety plan is to get the narrative, the story of the person. And the actual part of the safety plan is, going through the steps is much briefer. So what I would say is, so it probably could be done, that part of it, from the warning signs through means restriction, or means counseling, can be done in about 20 minutes. And so what I would say is, in the emergency department, the clinician probably has already done it, because they have to get the background information on how did this happen, why is the person there. So they already have the suicide story of the patient. So so that the 20 minutes that is like the narrative related 20 minutes, in a certain way, almost like shouldn't count towards the safety plan. The other thing I would mention is that with Ed Boudreau, we developed a computer-assisted safety plan that kind of helps the clinician do this in the emergency department. That we only did kind of feasibility, acceptability testing on that, so we don't have efficacy data with that. But there are it's an interesting idea about how to get things done in a way that is that requires, to do a safety plan that requires less of the clinician time.
Thank you. A couple comments that we received say that the safety plan appears similar to the crisis plan and the Wellness Recovery Action Plan, or WRAP. Are you familiar with that plan, and should a person have both, or would that be duplicative?
So I actually think that it's, I mean, the WRAP plan that is, WRAP is really great. But it's different than this. And if you look at what the crisis plan is, in at least my understanding of it, is it has to do with how do you know when somebody else should take over for you. The safety plan is kind of almost like the opposite of that. Like when you're having trouble, the crisis plan is when I'm having trouble and I can't be doing X, Y, and Z on my own anymore. So it feels, it seems to me it's a little different. And I think that there is a utility for both of these. And the one other thing I would mention is that for everybody with psychotic illness, you can see how having, doing a WRAP plan is, or engaging WRAP is, it could be very useful. But that it would only be for a subset of people with psychotic illness, those people who get suicidal, that you would do a safety plan. So I think the two are compatible. They're not overlapping, and but that they're only for, the safety plan is only for a subset, where the WRAP would be for everybody with psychotic illness.
Thank you. Another question we received is asking if we start with safety planning first, or do you work on establishing a relationship and getting an individual to engage and participate, and then follow up with the safety planning?
Yeah. So that's the point of the narrative interview. It's in part engagement and alliance building, especially important with adolescents who could be particularly not engaging. They'll say things like, "This has happened in the past, but I'm fine now. I made a mistake. Life goes on," and so to help work with them to engage them. So we think the more that you can engage them, the better the safety plan is going to develop.
Thank you. We've also received a couple questions asking if you are familiar with the My3 app and its safety plan tool, and do you recommend it?
I have not used the My3 app, but I am familiar with it. It does pretty closely mirror the safety plan as we developed it, but I do not know of research on My3. That doesn't mean it's not out there. I'm just not aware of it. There's been an explosion of safety planning apps in the last few years. The jury is still out about the effectiveness of the apps, but there are studies in progress that can support its use. I would just be very careful because apps get buried on a phone just the same way as you lose pieces of paper. So as long as the person is going to be able to use the app and find it and use it, that's my biggest concern. I'm sure there'll be, as time goes on, there'll be more studies coming out supporting or not supporting its use.
Thank you. I think we have time for one more question before we wrap up today's webinar. And I think the question that came in earlier asked, for folks who have been in the field for a while, what are some things that we should work to unlearn regarding safety planning interventions in the SMI population based on recent research?
I'll let Barbara answer this, but I have to say, with the suicide risk curve, clinicians often commingle the acute suicide risk from the more distal risk factors, of which SMI patients often have a lot of, and they focus more on the distal chronic factors or rather than the acute risk, and people get sidetracked. And so I think it's important to first address how are you going to keep the person safe during an acute risk. What are those risk factors for that person with SMI? Do that first, and then once that's gotten, you have a good safety plan, then go back and address the longer-term risk factors. I find that people often, in doing the narrative interview, they often get sidetracked into things that aren't as relevant as proximal risk factors.
Yeah, so I would just add to that. I agree that that is really important, and that I think that there is an assumption that if we take care of the primary problem, that suicidality, we don't have to address suicidality. And so one of the things that happens is the person comes in and they say that they're not suicidal at the moment, and then but they have all of these other problems going on, and then we've kind of put that, but they had a suicide attempt in the past, and we kind of put that aside, because they are not suicidal in the moment, we put it aside and we don't think about it, and it can kind of like sneak up on you if you don't kind of think about keeping it front and center. One other thing that somebody had asked about twice on this that I thought I wanted to, in the question box, that I thought I wanted to address had to do with what about people who are thinking about suicide for a long time. And so this is actually a very common problem, that there are people, not just with schizophrenia, but I've worked a lot with patients with borderline personality disorder who are chronically suicidal. And so it's, so they have this kind of like elevated suicidality, but it's when they flip, when it escalates from this kind of like baseline suicidal level to going up past that baseline. And so it requires a lot of kind of fine-tuning and kind of detective work on the part of the clinician to help the patient understand what the, okay, so you're walking around always feeling suicidal, but you're not always acting on your suicidal feelings. What gets you to move from thinking about it to thinking about acting on it or actually acting on it? And so it's not a perfect answer for Bethany, but that is the kind of the closest that we can get to that.
Thank you. I think with that, we're at time, so I will pass this off to Kelly to wrap us up.
Thank you, Flannery, and I would like to thank Dr. Barbara Stanley and Dr. Greg Brown for presenting today. And I would most importantly like to thank SAMHSA for allowing us to share this information with you. I'm going to switch the screen to a short evaluation and ask that you all take the time to fill this out for us. I will also say if you would like a letter of attendance, feel free to download one on your own at the top of the screen where it says letter of attendance. Again, thank you for joining us and enjoy the rest of your afternoon.